Record.
Let me see how it looks. Only people you can see is Jakir and Vic.
All right. We're going to be doing physiologic adaptation of the newborn to birth. Objectives. All right, adjustment to extrauterine life. Babies are breathing quickly and they have to maintain the respiratory rate. They're going to be replacing fluid in the lungs with air because while they're in utero, their lungs are filled with amniotic fluid. We're opening up the pulmonary circulation and we're going to be closing the fetal shunts. And we're going to allow pulmonary blood flow to increase and cardiac output to be redistributed. We're going to go through fetal circulation, so you'll see what I'm talking about. They're going to be providing energy to maintain their body temperature, which is very important in newborns, and we'll be covering that in depth. And support their metabolic processes. They dispose of water products produced by food absorption and metabolic processes, and they detoxify substances entering from external environments. So respiratory and circulatory function. In utero, like I said, the lungs are filled with fluid. They're filled with amniotic fluid. The baby will practice breathing, if you ever see it on an ultrasound, but they're not breathing like you and I are. Okay, they just do practice breathing. Their lungs are filled with fluid. Secretions of the alveolar cells of the lung have the fluid in there. Okay. And the surfactant is produced later on in pregnancy. Surfactant is like a lubricant, okay? That's what's going to keep the lungs from sticking to themselves, helping the lungs function. So when you have a preterm baby deliver, they might not necessarily have produced that surfactant. So if you happen to see one when you're at the hospital and neonatology is there, they'll say, okay, we have to give the baby some surfactant. That's what they're talking about. They're giving it to the baby to help get their lungs working.
So how does the amniotic fluid come out of the lungs?
We'll cover that too. You'll see, yes. Okay, so like I said, prevents the collapse of we had a small technical difficulty, so I paused it and then restarted it.
Okay. Will you sign this later?
I will. Prevents the collapse with expiration and promotes the lung expansion. The first breath of a healthy term infant occurs within seconds of birth, okay? So mom's up in stirrups, she's pushing, the head delivers, so they're gonna suction the mouth, they're gonna suction the nose, they deliver the baby, and the physicians or the nurses are drying and stimulating that baby to get it to cry. So that first breath literally happens within seconds, okay? Stimuli to the respiratory center. In the neonate's brain, it's all sensory, chemical, thermal, and mechanical. The external environment that affects it is like cold, touch, movement, light, sound. Chemical stimulus, once the cord is clamped, okay? It decreases the blood oxygen level, it increases blood carbon dioxide level, and decreases the pH. Acidosis results. It activates the respiratory center and in the medulla, and that's what initiates it. So like when your brain will know, like, okay, I don't have enough oxygen, my CO2 is going up, I need to take a breath, and it'll trigger the baby to take a breath. Changing from fluid-filled lungs to air-filled lungs. Okay, so as the baby is coming out vaginally, it's going through the birth canal, so everything is squeezed, okay? So you're squeezing that chest and all that fluid's coming out. It's coming out of their nose, out of their mouth, okay? But sometimes they do take a big gulp on their way out, or they have some excess secretions and we're suctioning the mouth or suctioning the nose, but most of that fluid is getting pushed out, okay, as it's coming through the birth canal. About half the fluid is out before the baby's even out, okay? So then the chest recoils, it fills with air, and the baby starts to breathe, okay?
So what happens to the other hand of the fluid?
It'll come out, it'll work its way out. They're crying. So when the newborn, comes out, they're on the infant care center, they're crying, that's a good thing. You want them to cry. You don't want them to be quiet. You want them to clear their lungs. You want them to take those deep breaths. They're gonna be changing their color. You want them nice, pink, and screaming, okay? So in a C-section, You don't have that same chest compression because they're coming out of an incision, okay? Now, you may see some physicians trying to do a smaller incision, the bikini line, they call it, to kind of mimic that action. If you get a chance to see a C-section, you might notice them trying to get the head to come out of this tiny little incision that's about this big, and it's like, well, why didn't they cut it any bigger? They're just they're trying to mimic that, okay? But you don't have that chest compression for that fluid to come out, so sometimes the section babies end up having a little bit more of a transition period. They have to get that fluid out. So they may end up having a little bit more deep suction at the infant care center, or you may hear some, gurgling, or you might hear them bubbling up with that fluid, okay? Some of it is, the fluid is absorbed by the lymphatic system, and the rest is removed by the pulmonary capillary, so just through the circulatory system. Okay, so functional residual capacity, it just means that it's established with the first breath. There's a small amount of air that's left in the alveoli, and that's to help the lungs stay open so they're not clamping back down, okay? And then with each subsequent breath, it just becomes easier and easier. Normal respiratory rate, you'll find this on your newborn assessment packet that I gave you, is between 30 and 60, okay? Sometimes, as you're listening to the baby when you're doing the newborn assessment, you'll hear small little periods of them pausing, they're not breathing, and you're like, what's going on? 5 to 15 seconds is completely normal. If it's like 20 seconds or more, it's apnea, and that's not good. You need to notify somebody, okay? But they do have those periods. And it's good when you go to do your assessment that you're actually listening for a full minute, so you can actually hear, do they have any apnea, or how many pauses they have in that time, okay? And any nasal obstruction can cause respiratory distress. So you want to be mindful of the babies who are breastfeeding. If mom's a little bit on the larger side, they're going to sit there and their nose is being covered and they can't breathe enough that they're trying to nurse them. And why did my baby turn blue? So you want to at least have one nostril opening. You're going to hear them sniffing as mom's sitting there breastfeeding. They breathe through their nose. That's just the way they are. All right, so fetal circulatory system. All right, ours, we take in a breath, it goes into our lungs, the blood passes through, we pick up the oxygen, we cycle it through, we get to our organs. That's how we work. When the baby is in utero, it does not necessarily follow that pattern, okay? Yes, the blood goes to the lungs, nourish the lungs, grow, mature, but you're not picking up oxygen. Your lungs are full of air, okay? So it bypasses the lungs. You have a small amount that goes, but the blood bypasses the lungs. When that kid is born, the cord is clamped, and they're taking their breaths, that all changes, okay? And we're going to go through so you can see how it does, and I'll show you a picture of it. In the newborn, they're just like us. Once everything starts going, they transition over to how we are. All right, closing of fetal structures, the shunts. Okay, shunts close as a result of the shift in the heart pressure, an increase in blood oxygenation, and clamping the cord. Okay, so all that stuff that's going on in delivery, cut the cord and clamp the cord and all that stuff. There's reasons for it. Okay, there's things going on behind the scenes, and this is a picture of fetal circulation. Okay, completely different from ours, isn't it? So the foramen ovale in the fetus, okay, it's an opening between the left and the right atria, so there's a little hole, okay? Blood flow and pressure are greater on the right side. It functions like a one-way valve. The blood shunts away from the lungs to the aorta, so it's bypassing the lungs. Just a little bit goes over there, okay? And the cord is clamped on delivery, and that will take care of that. Okay, it causes, in the newborn, once you clamp the cord, the placenta, the blood from the placenta stops, the pressure on the left side becomes greater, and it closes about a minute after birth, okay? It takes about 2 weeks for everything to be completely closed. Ductus arteriosus in the fetus shunts the blood away from the pulmonary artery to the aorta, again, bypasses the lungs. Pulmonary arterioles dilate in response to increased oxygen needs of the lungs at birth. So it constricts and closes between 15 to 24 hours after birth. Anatomic closure takes about 3 to 4 weeks, and it can reopen or dilate if and the baby can end up with a patent ductus arteriosus. Okay, you see that in your books. A PDA, or patent ductus arteriosus, can lead to right-sided heart failure and pulmonary congestion. If it does reopen, unoxygenated blood will bypass the lung and go to the pulmonary artery, into the aorta, and through general circulation. So this kid's going to become hypoxic and can die. Okay? Ductus venosus allows most of the oxygenated blood to bypass the liver and enter the inferior vena cava. Clamping the cord at birth cuts off the venous blood flow. Blood is redistributed on clamping of the cord. Reduction of blood flow through the shunt constricts and closes anatomically about 2 weeks after birth. It forces blood perfusion to the liver. Your liver is your filter. And they don't know why this happens. Okay. Body system adaptations and functions. Thermoregulation. This is a big, important thing. I can't stress it enough. Babies are not able to maintain their temperatures like we do in the very beginning, okay? They come out, they're wet, they're cold. You know, you want to try to dry and stimulate them as much as they can, warm them up, and it's very important, and you'll see why. All right, so the ability to produce heat and maintain normal body temperature. The newborn maintains heat by flexing the extremities if the tone is good, okay? Otherwise, if the tone is not good, they're out like this, and what happens when you're out like this? You're losing your body heat, right? So you want to kind of stay close. They like that. It keeps them warm, okay? It decreases the risk of cold stress. Okay, so we want to try to maintain their temps around 97 degrees or greater, okay? 97.7 would be best, or greater, okay? By doing that, you're allowing the baby to not have to stress itself out. And by stress itself out, I mean, you know, trying to maintain temperature, using up glucose stores, and it's one like big vicious cycle for them. Okay.
So, because they need to make sure with the temperature for them to have a fever is the same as
It's the same as ours. Yeah. So if you have a baby and they have a temp of 100.4, it's a temp like ours, 100.4. But we want to maintain their temps because they can't shiver like we do. If we get cold, we shiver, our body heats up, and we're good. With the babies, they can't do that yet. They use something called brown fat, and we'll cover that.
That's the organ.
So, okay, newborn response to increase in basal metabolic rate and oxygen consumption. So, okay, I'm cold, and I'm using my oxygen, and you know, my glucose, and I'm trying to get myself warm, and now my glucose is dropping, and all of a sudden I'm going to become lethargic. So, you see how I'm going? But I can't, you know, can't do it. So, things that contribute to heat loss. They have a thin skin. Blood vessels are close to the surface. They have little subcutaneous fat for insulation. Even the chunky babies, even the ones that are like 9, 10 pounds, they don't have as much fat. Okay, and there's a greater transfer of heat. So if you take a baby and you stick it on a cold scale, guess what? That cold scale is going to suck up that heat and that kid's going to get cool. You know what I'm saying? All right, so there's 4 ways of losing heat. Evaporation, so wet surface, exposed to air. So baby comes out, covered in amniotic fluid. Same as us, like you get out of the shower and all of a sudden you get a chill. Same thing. Conduction, loss of heat to a cooler surface by direct skin contact, so that cold scale, okay? Convection, loss of heat from warm body surface to moving cooler air. Oh, it's a beautiful day, I'm gonna stick my kid by the window. Guess what? It's gonna lose heat that way too. And then radiation, okay? So loss of heat from warm object to a cooler one when they're close together, okay? Non-shivering thermogenesis. So a newborn, like I said, they can't use muscle activity, they can't shiver. They have difficulty conserving and dissipating the heat to maintain their body temperature, and they rely on non-shivering thermogenesis. This is where the brown fat comes in, okay? You vasoconstrict in cold environments and vasodilate in warm environments. Okay, so if you think of it being cold, your vessels are going to constrict, they're going to shrink. And when you're hot, your vessels are going to dilate, okay? Hypoglycemia is the other culprit that goes along with it. So a blood glucose level less than 40, okay, is considered hypoglycemia in babies. That kid needs to eat, okay, very important. And some labs will say, like, if you get a sugar like this, then they'll have to end up drawing a serum just to validate that that's actually what it is, okay? Newborns produce heat by physiologic mechanisms or thermogenesis. It includes increasing their metabolic rate, muscular activity, chemical thermogenesis, which is the non-shivering, and that's their primary method of heat production. So your brown adipose tissue, your brown fat, it's basically that fat. It's abundant in blood and nerve supply, and as it's metabolized, the heat's produced to the vital areas of the body. It can be depleted in newborns who are exposed to prolonged periods of cold. They only have so much. They only have enough to kind of get them over that 3-month hump, and then that's it. So if you're constantly stressing your kid out and it's cold, it's going to use up all those stores, and then you're in big trouble, okay? And this is where your brown fat is, okay? The biggest pad is between the shoulder blades, okay?
So underneath of that skin there is no real fat?
They have fat, but it's just not a lot. They have this.
So that protects them.
That helps them. It's kind of like their buffer, okay? But if you use it all up before they, go over that hump, that 3 months, they're not going to be able to.
Oh, it's 3 months.
It's up to 3 months.
Oh,
So,
okay.
so this needs to last them up to 3 months, okay? And with preterm babies that haven't had a chance to make this much, they have even less to work with, okay?
Is that why they say don't take the child outside for at least 2 or 3 months?
Not necessarily outside. I mean, it could be inside. You can have the air conditioning blasting. You want to be mindful of their temperature. You don't have to bundle them up so they look like Eskimos, but you want, dress the baby as you would dress yourself. If you're chilly, chances are your child is chilly. You can always keep an extra blanket or something like that around, but you want to be mindful of their body temperature as well.
Yeah.
Yes, yes. So you don't want to sit there and put, a onesie and then a thin pajama and then a pants and a jacket and then a blanket and then a hat and coat. Like, forget it. Your kid's going to overheat. You know what I mean? Dress them as you would dress yourself. Okay? So with newborn temps, you want to assess them every 30 minutes and then each hour, like after that period, that initial period, every 4 hours and then once a shift, so once every 8 hours. And 97.7 is like the standard, okay? Okay, so normal vital signs for a baby. What are the respiration, what's the respiratory rate, normal rate? 30 to 60. Okay, heart rate? 80?
110.
Oh, no, it's 110 and 160.
Okay. Some textbooks will say 120 to 160, 110 is okay if they're at sleep, like at rest, it's okay. But you can do like 120 to 160.
So 180 is too high?
180 is too high. 180 is tachycardic. Yes.
Oh, okay.
So if you see them on ultrasound and you see that they have about 180 would still be too high?
Well, I mean, they could go, if their heart rate, their baseline is sitting at 160, and they move around and they have an acceleration, it's not, you're not going to be weird about seeing something at 180, as long as it's not staying there. It'll go up to 180, great acceleration, and it comes back down to baseline, fine. If it goes up to 180 and stays there, is there something else going on? Does the baby have a, fever? Does mom have a fever? Like, if it's still in utero, does mom have a fever? So you don't want to see 180, okay? So newborn assessment, things that you're gonna be doing, are ASCAR scores. We're gonna go over that. Identification of the newborn, immediately, okay? This is a big, big thing. You don't wanna be giving the wrong baby to the wrong mother. And if you're the mother, you don't want the wrong child, okay? And then if you're breastfeeding, you know,
Okay, you're about to tell us to do it immediately, when our other teachers told us to wrap them up immediately, then put the
But
braces.
some people don't want the babies wrapped up, they want the babies
they
right
can
on.
do skin to
Which
skin,
one?
that's fine. Here's the thing, okay? So in the delivery room, you have the delivery nurse, so she's taking care of mom. The baby comes out, you have a baby care nurse, okay? The kid goes under the warmer, you're drying and stimulating the baby. That baby is not to leave that room in any way, shape, or form without being properly identified, okay? So we're in the room, all right? So when you actually get the medical record number from the baby, you're filling out those bracelets, you're verifying either with the mother, the father, the partner, whoever's there, or even another nurse, that the information you have on those baby bracelets is correct, and they go on the baby. Okay, that baby is not to leave that room unless it's banded, and the other band's on the mom and whoever the second person is. Because when that baby comes back to her, they have to say, oh yeah, baby boy, you know, John Smith, you know, born this time, this day, medical record number, and your bracelet number. Okay, because if you're the mother, do you want to be breastfeeding somebody else's kid? Or, you know, God forbid, you know, take home the wrong baby? No, absolutely not. So ID that baby. Okay? Yes, maintain more. Yes, do your assessment. It's all simultaneous, but that kid needs to be banded.
Before you did it.
That kid is not to leave the room.
Right.
Not banded. Okay? And then provide warmth, obviously. Protect from infection and complete the physical. All right, so full-term infants are born with these reflexes. They can blink, they can sneeze, gag, suck, and grasp. They can also cry, swallow, lift their head slightly, and then when they're laying on their belly. So you may see them kind of do like one of these things and then come right back down. But don't trust them. You have to be there because they'll go right into the blanket and that's the end of it, okay? So yes. Tummy time is great because it'll strengthen their neck muscles, but you never leave them unattended, okay? They can also taste and smell. All right, so the assessment is an ongoing thing. It's a series of examinations. And you're looking at skin color, you're looking at the types of respiration. Are they normal respiration? Is the baby grunting? Is it retracting? Are the lungs clear or do you hear something? What's the temperature of the baby? What's it doing? Is it flexed? Is it not flexed? Is he sleeping? You know, what's going on? And how are they eating? Are they eating? Are they vomiting? Are they refusing to eat? What's going on? All right, pop quiz. 4 types of heat loss. All right, yay. And that is chapter 9.
So, does that give, so that would give them heat, the skin to skin?
Yes. So it's to promote maternal newborn bonding, okay? Once everything's all said and done, you banded your baby and everybody's okay, you can have mom take her gown down and put the baby bare, skin to skin, right on the mom. If she's a breastfeeding mom, it's great because they're right there, her body's providing warmth for the newborn, and they're bonding. If she's not a breastfeeding mom, she can still do skin to skin, you know, just to bond with her baby. But you want to cover her and you want to cover the baby. So you can put like a warm blanket around her shoulders, the baby's right here, put like a couple baby blankets and just kind of wrap them around each other. So they're just like cocooned with each other, okay? And it's not uncommon to see or offer the dad to do skin to skin. You don't want to forget him.
I know.
You know, he's part of this too. So maybe mom had, you know, an emergency C-section and she was under general anesthesia and she's just not feeling right. But dad can bond with the baby, or if, you know, mom has a partner, you know, the partner can bond with the baby. So you can do skin to skin with them too.
So is that from adoption?
What?
Adoption?
Yeah, dad to baby, yeah, or mom, you know, the partner to baby. Okay? All right, do we have any questions on chapter 9?
They overdo the test.
A lot, no, a lot of it.
A lot of it will.
A lot of it's beyond.
But it's like a refresher.
Then it should be a good review. All right, now, I have 10 and 11 combined, and then I have 11. 11 has a lot of stuff in it that we're gonna cover now, so just by going over it, it's just for reinforcement, okay? All right. Hey, baby. Hey, cute. I don't know who it is. All right, so your assessment, you're observing, you're inspecting, you're auscultating, you're palpating, and you're percussing, okay? You're doing all these things. And we went over this. So know your APGAR score, identify. All right, so your APGAR score is done at 1 in 5 minutes of life, and in some cases, if there was, some kind of resuscitative measures that they needed to do at delivery, you might actually get a 10-minute APGAR, but your 1 in 5 are the most, important. So you're looking at color, which is your appearance, heart rate, which is your pulse, reflex, which is your grimace, which is like, it just depends. Your activity, which is what it is. Are they like this? Are they like this? If you pick up the arm, does it come back down or does it flop to the side? And respirations, how are they breathing? So your heart rate. Your APGAR score is based on a 0, 1, or 2. Okay, so you're getting a 0, 1, or 2 for each of those categories. A 0 obviously would be no heart rate. Less than 100 is 1, greater than 100 is 2. Okay, so either 0, 1, or 2. Your color, do you have central cyanosis, peripheral cyanosis, or completely pink? Now the peripheral is completely normal. They're gonna come out, they're kind of like that bluish purple, they start crying, they pink up, their trunk should be pink. Their little hands and feet are okay to be a little blue and purple. And they'll be like that for a little bit, and then they'll pink up. Respiratory effort, they're either apneic, they have irregular, shallow breaths, or they're crying. Crying is awesome. You want them crying. Crying would be a 2. Reflex, they either have none, they kind of grimace, so they're like, or they're crying. Muscle tone, they're flaccid, they have some flexion, or they're well flexed. Okay? And again, it's not performed one and done, it's an ongoing assessment, so you want to be watching these guys very closely. So in the delivery room, we're looking at heart rate, respirations, are they normal? What's their APGAR score? You're doing a quick overview of their body, assess the cord. There's nothing, some places still have them put something on the cord to help promote drying. Most places do not. Just as long as you maintain that cord is nice and clean and dry, and it'll just fall off by itself. You really don't need to do anything special with it, okay? ID and the alarm, the little low jack, little house arrest anklet that goes on them, usually they'll put those on right after they give them a bath. Some places actually have it in the cord clamp itself, so if that's removed, or the bracelet, the anklet's removed, the alarms go off. Possible AccuCheck, so was mom diabetic, was she on any special kind of medications? Is the kid preterm or post-term? Certain protocols are followed for doing AccuChecks. Dry the baby, swaddle the baby, and hand it off to mom. Okay. Hypothermia, again, we want to avoid this, okay? It increases cell metabolism, it increases their oxygen consumption, and it can cause hypoglycemia. So again, hint, thermoregulation. This is that skin to skin, also known as kangaroo care. Isn't it cute? Helps to maintain the baby's body temperature. All right. Phase 2 is in the newborn nursery, between 1 and 4 hours of age. Vitamin K is a shot that they give them in their thigh to help with clotting. They can't synthesize vitamin K without the presence of bacterial flora. Their gut's sterile. Right. So right in their little thigh. Emycin, erythromycin drops, the ointment in their eye. Okay? And Why do we do that?
Protect from STIs, right?
Well, yeah, and plus, you know, you're passing through mom's vagina or, you know, through, you know, her abdomen, picking up whatever is there. Oh, you might see in the eye, all right? Weight. We're gonna do this in the delivery room. Everybody wants to know what their weight is. Some places will have certain protocols in place, so if the baby is under a certain weight, they'll need AccuChecks. If it's over a certain weight, they're gonna need AccuChecks.
Is there a range?
There is, like 5'11" to 8'13". So if the kid's 5'10", it'll need sugar.
Or
if
10
it's like-
pounds?
Or 10 pounds, it'll definitely need sugar. Yeah. All babies will lose a few ounces within like that first
Yeah.
day or two. If you're getting to like a 10% weight loss, then, and mom's a breastfeeder, you know, she'll need to either bottle feed the supplement, or if she's a bottle, you know, if it's a bottle baby, then they're gonna need to eat more. Like, you have to, you know, that's too much. Okay? And the pediatricians will tell them that too, all right? So you're gonna measure their length, you're gonna measure their head circumference and their chest circumference. You just use a little paper tape, and then you document it in centimeters. And you wanna support the head, always, always, always. They do not have very strong necks. So if you just pick up the kid and not support the head, guess what? It's gonna go this way or like this. You need to support their head and neck, and you need to stress that to mom, especially when she's like, you know, sitting there holding the baby. Support the head and neck. You wanna grab them from here, okay? Because otherwise, they're just flopping all over the place. Not good, okay? And make sure that you stress they put the baby on their back to sleep, okay? You can change positions while they're, you know, awake, or you're awake and hanging out with the baby, otherwise you have a nice flat head, but back to sleep, always on their back to sleep, okay? All right, Hep B vaccine, everybody's a little different with what they want to do with this. A lot of places will offer it in the delivery room or the nursery. Some parents want to wait and talk to their pediatrician, which is fine. Some don't want to give it in the hospital, they want to give it at the pediatrician's office, which again is fine. Short of homeschooling your kid, they will eventually need this series of 3 shots to go to school. You get the initial one, the second one's a month later, and the third one is 6 months later. Okay? So some people say, you know what, they're already getting their medications in the nursery, I might as well give them the Hep B too, and that's fine. Okay? Circumcision. This too is up to the parents. It's a personal preference. It may be a religious thing. It may be a cultural thing. They, you know, don't want to do it. They're going to have a bris, you know, if you're Jewish, or, you know, we don't want to do it. We don't believe in that. Or I want to do it. You know, they say like a rule of thumb: if dad is circumcised, then you circumcise your son, because one day they'll see their dad and be like, "Why are you different than me?" So, again, there's no right or wrong behind this. It's cosmetic. You just want to tell them, if you do not circumcise the baby, you want to make sure that you actually pull the foreskin back and clean under there, because you can get an infection. So make sure that you pull back, clean, and pull it back over.
Does the foreskin have a purpose? Like, is it flawless and neutral? Or
No,
just-
it's just extra skin. Yeah, it's there.
Why did they start to do that?
Yeah.
Why?
Different
I mean, they're
times.
born that way, so what is the reason?
Was it the hospital that started it, or was it the same?
No, I think it was just something that they,
Jewish religion.
well, they do that at like 7 days of well, like a week later. They have a ceremony, like a little ceremony and everything. I mean, it dates back to like, back in the day as far as doing it. I mean, it's cosmetic, I guess.
Don't think
They-
it's more for like prevention.
I mean, some people are like, I don't want to deal with pulling the foreskin back and cleaning it, or, you know, something can happen later in life, just get rid of it, and they, you know, circumcise their boys. Again, it is completely personal, you know, and you do have to obtain a consent before they do that, so you can't just go and circ the baby, you know, you can't do that. If they do opt to do the circumcision, there are 2 methods they can do. One is a gum cone, one is a Mogan. They will pull they will kind of pull the foreskin back and put this little bell on the head of the penis, and then they will cut, you know, like around, or the other one looks like a little guillotine where they just kind of snap it off, you know, yeah. So the physicians or the like the OBs or the pediatricians will do this, nursing does not do this. We are responsible for taking care of it after the fact. So once the foreskin has been cut, they will put on this gauze that's kind of gooped in petroleum jelly or Vaseline, and they'll put it on there. And then an hour later, we go in, we take off that gauze and we look at it. Is it, you know, is it actively bleeding? Is it oozing? Does it look okay? A little few dots of blood in the diaper is completely fine, but you don't want to continuously see that. If you do, you want to call the pediatrician or the OB, whoever did it. Also, it's surgery, you know what I mean? So is there an infection? Is there, you know, any odor to it? So you want to instruct the parents, make sure you look for signs and symptoms of infection, any kind of redness. The initial assessment of the circ they'll be red, and then it'll eventually go to pink. You put the Vaseline or petroleum jelly on there to keep them moist so they don't stick to the diaper or to themselves. It takes about a week, 10 days or so for it to completely heal, and sometimes you may see like this yellowish looking stuff on there. Don't scrub it off, just leave it go. And if by whatever reason they end up having a bowel movement and they maybe sat in it a little too long and it dried on there, don't scrape it off either. Put on some Vaseline, get the poops off, and then clean them. Okay, you want to make sure that everything's clean down there, but you don't want to hurt them in the process. Yes.
Did you say that, for the method that is used for circumcising, that
The doctor's, yeah, the doctor's preference as far as like, yeah. Some of them like to use, you know, one type of equipment, the other ones like to do the others. It's really doctor's preference. And the result is hopefully the same, you know? But yes, that's the physician preference. They do. Some places will do Emla cream, which is just like a topical anesthetic, so they put it on there and then they wait for it to get numb. Some will actually inject lidocaine into, like you go to the dentist, they give you a little, you know, Novocaine. They'll inject some lidocaine at the base so they can numb it, and they'll do the passy with the little sweeties in it, so they'll try to keep the baby calm. And then some places will do 1 dose of Tylenol per physician order for pain, because you're not supposed to give Tylenol for the first 6 to 8 weeks of life unless instructed by your physician. But post-circumcision, they'll do 1 dose of Tylenol. They're just too little for it, yeah. Unless there's some kind of like major issue, you don't give them Tylenol like at all. So, all right, so again, complications, you have infection, you have your hemorrhage. Assess for pain, swelling, bleeding. Make sure that they're voiding, okay? That's a big thing. After they get circumcised, you want to make sure that this kid is actually urinating. As far as the bleeding, like I said, a couple drops, fine. Anything more than that, you need to call them. A couple of times I've seen circs that have actually actively bled, and they'll come in and put like a little silver nitrate on it, and it'll cause the skin to turn black, but it cauterizes that bleeding. It just kind of stops it right there. Yeah.
How can we assess a baby for pain?
Well, if you got cut, what would you do? You'd be crying, right? You don't want to be bothered. So if it's time for them to eat, they might not be interested in eating. They want to just be held. So just like us, like when we're in pain and we don't feel good, you know, we might be crying, you know, we might be, you know, not interested in anything. Yeah, we just want to sleep. All right, so for uncircumcised penis, avoid forceful retraction. Wash with water only. For the toddler, gentle retraction during bathing and drying to prevent moisture from accumulating under the foreskin. And for the school-age child, you need to teach them to retract and then at least once a week during the bathing. And then full retraction may not be possible before puberty. Right?
So you might not be able to retract the skin
before, like all the way,
Oh,
before,
okay.
before puberty. It just depends on.
Now, what if you're like, oh, I have a son, and then I decide not to get it, and now he's 4, and I'm like, oh, you know what, I want him to get this,
That would be up to you and your pediatrician. You have to discuss
Is
with
it
them.
possible?
It's always possible. I mean, there are grown men who are not, circumcised, and then for whatever reason, they have to do it later in life, and it may be very painful. I mean, it's surgery in a very sensitive area. So I think that's why, one of the reasons why they do it when they're newborns, because it's like, oh, they're small, they're gonna forget, they're not gonna remember. Whereas with a 4-year-old or, a grown man, they're gonna remember, unless, it's different. Yeah. All right, car seats. Must have one before you take your baby out of the hospital, okay? They will not release your baby without a car seat, okay? Rear-facing position, at least until they're about a year of age or so, and 20 pounds. And you don't want them sitting bolt upright, you want them reclined a little bit, so 45 degrees. If your newborn is less than 37 weeks, Respiratory will usually do a car seat test. So they'll put the baby in the car seat, and they'll put, the pulse ox on, the monitors on, and they're gonna watch the baby. Because what happens when the baby's in the car seat and, mom or dad are driving and they're in the front seat and the head's like this, guess what? We're gonna cut off our air supply. So we wanna make sure that the baby's able to sit in the car seat, even if its head's down like this a little bit, and still be able to breathe. Oral and nasal suctioning. Sometimes they have some mucus up there and you just need to get it out. You want to use a bulb syringe. You don't want to be forceful with it. And if you're teaching the moms and dads how to do it, you want them to just show you, just to make sure, like, you gently put it up the nose, make sure you squeeze it over the nose and then let it go to suck out anything that's in there. Same thing as far as like their mouth is concerned. Maybe they, newborn, and they have a little mucus in there, and they kind of collected it in their cheek. You want to suction it out, but be gentle about it. Any kind of cracks in their skin, you want to be mindful of, just for infectious purposes. Sometimes you'll see newborns that come out, and maybe they're, post-term, and we're washing them and drying them and putting clothes on them, and now they got all this dry, scaly skin on their hands and feet, and that happens. You just want to be careful that there's nothing going on, with that. Signs of infection in newborn: poor feeding, lethargy, periods of apnea, and obviously any kind of drainage, redness, or possible odor. You want to general appearance as far as the newborn. What do they look like when they're resting? Do they have any kind of spontaneous movements, and what are they? Flexion and symmetry. Everything with the baby, you'll see, is symmetric. It's supposed to be symmetric. The eyes, you're supposed to have two eyeballs, and they're in the same spot. The ears are supposed to be level. 2 patent hairs, okay? And like 5 fingers, 5 fingers, 5 toes, 5 toes, radial folds, that kind of thing. Brachial pulses, femoral pulses. All right. Central nervous system, extension of the neck with an arched back is indicative of the CNS problems. Any spontaneous movements could be potential clues, CNS movement. So seizures, or just some kind of spastic movement, as they're just sitting there, or they're just kind of like this. Newborns cry. Should be strong and loud, okay? Anything that's high-pitched may indicate a neurologic disorder, hypoglycemia, or a drug withdrawal. Vital signs, again, should be taken frequently in the beginning, then hourly, then 4 hours, and then 8 hours. Apical rate, listen for a full minute. Now, when you guys get to clinical, if you can, assess a newborn, put the stethoscope on and listen to their heart rate. Listen to their respiration. Try to separate them and see if you can get their heart rate, see if you can get their respiratory rate. You have to listen very, very good, very carefully, okay? Don't look at their bellies that they're breathing. Listen. Listen on both sides. Are they clear? Okay. As far as the minute, maybe you hear a murmur. You know, you wouldn't pick up on it if you only counted for, 6 seconds or 10 seconds or whatever it is. Listen for the full minute. All right, so again, your newborn rate is 110 to 160. Under 110 is bradycardia. Anything over 160 is tachycardia. Okay, femoral pulses. So you want to feel in the groin 2 pulses. They should be nice and strong. If they're weak or slow, could be something, coarction of the aorta. Okay, so right in the groin. Respirations, again, we cover this. You want to make sure. All right, nasal flaring or any kind of retractions, grunting, not good. You want to let somebody know about it. Okay, this kid's struggling to breathe. Okay. Breath cells should be clear. If you notice anything as far as rails, bronchi, maybe you want to pump their back a little bit, stimulate them, try to get them to cry. Attempt it good. A lot of this stuff is repetitive, but just review it. Blood pressure. So at birth, you should be between 60 and 80, diastolic between 40 and 50. When the baby's crying, obviously it's going to change it. It's going to increase it 10 to 20 points. If there's any kind of cardiac anomaly, check pressures in all 4. But usually you just check in the one arm. Get a pressure. All right. Skin. When the baby's born, they come out there a little bluish purple. They pink up. Everything's fine. When they have a little green to them, what's going on? Meconium. Right. So how long was the baby sitting in meconium in utero? Was it just right then before delivery, or did this kid, sit in it for a while?
So, is that why somebody had butt surgery?
Well, it
Or
depends.
is that something else?
That, if it's like a dark blue, purple, like a bruise almost, that's different. That's a Mongolian spot. We'll cover that. If they are actually tinted green, like a greenish yellow, or if you look at their umbilical cord and then there's like a green or yellow tint to it, they've been sitting in meconium for quite some time. It's called meconium staining. Yeah. So you want to assess their skin, look at them, see what's going on. Any kind of peeling or excessive cracking could be post-term. Kids in there, what happens when you're sitting in the tub for a long period of time? You're all peeling. All right. Lanugo is that fine hair that covers the baby. So when they come out, you're like, oh, they're hairy. Like, what is that? It's lanugo, okay? And lanugo's in place to hold on to the vernix, which is that cheesy white stuff, okay? So you sit in the tub for a long period of time and you're going to get permeate. Well, what happens to them if they're sitting in there all that time and nothing's covering them to protect them, right? So the vernix will help protect them. It's kind of like nature's own lotion, and that's what helps to keep them like nice and smooth, so they're not, sitting there getting waterlogged. And the lanugo will hold it on. Okay. Mongolian spots. They're the bluish purple ones. You'll find them most frequently on their backside or their butt. I actually had a baby yesterday who had multiple spots all over their body, and they had one big one right here on the hand.
What is it?
It's just something that you're going to see a lot of in black babies, Indian babies, Asian babies, or like Mediterranean descent. Okay. It's some of they'll sometimes they'll shrink down and they'll go away. Some of them will actually kind of have like a little bit like left over, but you come out and you just see like this black and blue spot right on their butt,
That's what they call it, a birthmark.
It's a Mongolian spot. Okay.
Will it go away?
This does. It fades. It fades.
What if it don't fade?
And you're stuck with it.
Yeah, because he had no blood and it faded, but he got a
Little tiny one there.
right there.
Stuck with it.
So they're not raised, or they?
They're not. They're just kind of. It almost looks like you have a bruise.
Yeah.
Just a bruise, but it's not. It's a Mongolian spot. And then you have the little strawberries. They have on the Caucasian babies. They'll sometimes get them back here, or they get them over here. Okay, So with these, they can raise, they can come up to 6 months and disappear by age 10. Now, depending on how they are, my nephew, I believe it was, had a, like a hemangioma. So he had like a little strawberry here and a little strawberry here, and they were just kind of like, oh, you know, like, what's up with that? Here, come to find out, it will actually get bigger before it goes away. So the little spot that was on his arm right here actually grew to about this big and then eventually disappeared. And then the one on his head, same thing, got real big and then it disappeared until it's completely gone. So some of them don't go away, but usually they'll get bigger before they do. After cyanosis, like I told you, the hands and feet are still a little blue and that is completely fine. A lot of people do worry about it because they're like, well, you know, why are the hands and feet still blue? Like, what's going on? It's just normal body functions, okay? They will eventually pick up. The head is born first, obviously, out of the vagina. They don't do breech deliveries as much anymore. It's often elongated, okay? So you're coming through the birth canal, and guess what? Your head's gonna mold to get down there. So it's gonna come out and it's gonna look like a little cone head, okay? It will resolve, you know, the head on it, you won't notice it as much. C-section or C-sections don't have that molding, so they're gonna come out with a rounder head, or breech delivery. Like they don't do those as much anymore, but you didn't have as much of that molding happening with breech babies. You had a little bit, but not much. Head circumference is about 13 to 14 inches, and the head is bigger, at least by 1 inch, than the chest. Okay, so head is bigger than the chest. If the head is more than 4 centimeters greater than the chest, there might be a little hydrocephalus going on. Why is the head so much bigger? Okay. Maybe there's a little bit fluid going on. Yep. A small head or microcephaly might be caused by rubella or toxoplasmosis exposure. So you want to measure the head circumference of the baby. Molding is just the overlapping of the bones, just from head compression, and like I said, will resolve in a couple days. Here's a picture of tappet. It's just the swelling of the soft tissues of the scalp caused by pressure during delivery and labor. It's palpated soft. Okay, it may cross over the suture lines. So your suture, your